Welcome back to week 6, part 2. In this section, we are going to discuss disorders of lung inflation, specifically pneumothorax and pleural effusion, and then treatment with chest tubes and or thoracentesis. So what are some of the causes of disorders of lung inflation? So what makes a lung be compressed or a lung collapse? Well, there's three main causes. The first one is pleural effusion, so it's compression of the lung with an accumulation of fluid in the pleural space. Pneumothorax is a complete collapse of the entire lung with air. And the third one is a collapse of the segment of the lung, as in Adelectosis, and I'm going to discuss these in more detail. So Adelectosis focuses in on the alveoli. So it's a condition where the alveoli are deflated down to little or no volume. And it's different from pulmonary consolidation, as in what we spoke about in chronic bronchitis with mucus, or with pneumonia, in which they are filled with fluid or purulent drainage. In Adelectosis, they are collapsed. And it's just the small alveolar structures that are collapsed. And I would see this quite often with my heart surgery patients after going through surgery. You often see it with any type of thoracic surgery or people who are in bed rest, that their alveoli collapse. And so the signs and symptoms are an increased respiratory rate, they are tachycardic, they have shortness of breath, there may be cyanosis, and you will hear absent breath sounds on the side of the lung. It's typically in the bases that you hear this adelectosis. There's just a loss of breath sounds in that area. It's silent. So that's different in that it speaks to the alveoli. With pleural effusion and pneumothorax, we're specifically speaking to the pleural space. And so just to remind yourself that the pleural space is between the visceral and the parietal pleura. The parietal pleura is on the outside of the lungs and it binds to the other structures in the cavity. And then the visceral pleura is actually what lines the inner part of the lung. And there's a space between this. And that's where you get the accumulation of air, the accumulation of fluid. So I've alluded to this already. So a pneumothorax is the accumulation of air within the pleural space. And as a result, you can see this accumulation of air, it causes a complete or partial collapse of the lung. Pleural fluid is a collection of pleural effusion is the collection of pleural fluid in the pleural space. And you can see that fluid actually accumulates, and depending on the amount of fluid dictates whether you have a complete collapse or just a partial collapse. So pneumothorax, again, I said it was the presence of air causing a complete or partial lung collapse. There are different types of pneumothorax. And I will discuss the four here: closed, open, tension, and hemothorax. So a closed pneumothorax has no external wound. And so it's often called spontaneous pneumothorax, which is the accumulation of air in the pleural space without an incident. There's no reason for it to happen. Oftentimes you see this with young adults for some reason, and other times I see it with COPD patients where there's these rupture of small blebs, which are air-filled alveolar dilations. Open pneumothorax is when air enters the pleural space through an opening in the chest wall, and typically you see this with your gunshot or stab wounds and during a surgical thoracotomy where you're actually cutting into the pleural space. A tension pneumothorax is the rapid accumulation of air, and it can happen from either a closed or an open pneumothorax, but it's more so it causes tension and it shifts. You have a mediastinal shift and a tracheal deviation with a tension pneumothorax. So it's this rapid accumulation of air. There's a high pressure and it causes tension on the heart and other vessels. And so as you can see from this picture, you can see from the midline here that this is where the collapsed lung is happening, and it's pushing over and it's pushing the trachea over to the lung that is not infected or inflicted. And so this is the side where something has happened on this side. You have a collapse of the lung and the pressure pushes everything over. So this is an emergency situation. And typically what happens is a physician or an MP will place a large bore needle into this pleural space to quickly evacuate the air. Hemothorax is accumulation of blood in the pleural space, and it's frequently associated with an open pneumothorax, so a gunshot or a stab wound, or a surgical thoracotomy, and is sometimes called a hemopneumothorax. It could be an accumulation of both air and blood and called a hemopneumothorax. So what are the clinical manifestations? Well, if it's a small pneumothorax, you may get some mild shortness of breath and some tachycardia. If it's a large pneumothorax, typically patients are going to be in quite severe respiratory distress, shallow rapid respirations, dyspnea, air hunger, and decreased oxygen saturation. Obviously, there'll be decreased air entry to the lung that's infected. There may be some chest pain, and if there's a tension pneumothorax, you will see this tracheal shift. And as I said, the tension pneumothorax has tension on the heart, so it causes hypotension and tachycardia because it's constricting the heart, so it's hard for the heart to pump, so the low blood pressure, but the heart is also compensating by trying to beat faster. So how do you diagnose it? So you can listen to the lungs and you can definitely hear it, that there's decreased air entry, but you diagnose it first with chest x-ray, plus or minus a CAT scan, your clinical exam, ABGs, and your saturation. And the treatment is secondary to the cause and the extent. If it's a small pneumothorax, it may respond or it may resolve spontaneously. Typically, patients will need supplemental oxygen, and the pleural space may be aspirated. So just as I've said, through a thoracentesis to remove the air, an insertion of a chest tube, or a needle insertion, if it's something that needs to be done very quickly as a tension pneumothorax. Pleural effusion, as I said, is an accumulation of fluid in the pleural space. There's two types, and the type is dependent on the protein content of the effusion. If it's a low protein, it's transudative, and if it's high protein, it's exudative. And that sampling can come from a thoracentesis. Empyema is a type of pleural effusion that contains pus, and so you'll have an accumulation of white blood cells, and it's usually treated with antibiotics. So the clinical manifestations, very similar to the pneumothorax. So shortness of breath, you're going to have decreased movement of the chest wall on the affected side. There may be pain, dullness to percussion, absent or decreased breath sounds. And again, if it is empyema, you're going to have the signs and symptoms of an infection. So fever, night sweats, cough, plus or minus weight loss related to the infection. Diagnosis and treatment is the same. Chest x-ray, sometimes an ultrasound is done to assess where the fluid is. CAT scan, and treatment is thoracentesis, plus or minus chest tube drainage. So let's move on to chest tubes and pleural drainage. So starting with thoracentesis, so it's a procedure where a needle is inserted into the pleural space between the lung and the chest wall, and it's done to remove excess fluid from a pleural effusion, to increase the space, and to improve breathing. And there's two types done. One is diagnostic to see if a patient, looking for the protein content, plus or minus empyema, and others is for therapeutic reasons because the patient is experiencing dyspnea. So in a thoracentesis, the patient is in this position, so they're sitting and they're leaning over the bedside table in order to get the proper positioning. Typically, 1,000 to 1,200 mils of fluid is removed at one time, and anything more than that can cause hypotension and hypoxemia or pulmonary edema because the rapid release of fluid from that space. So it's actually no more is done than 1,200. So I'm going to show you a picture of a thoracentesis, or sorry, a video of a thoracentesis.
Thoracentesis is performed to assist in the diagnosis and therapeutic management of patients with pleural effusions. After anesthetizing the skin in the typical wheel fashion, anesthetize the deep tissue. Insert the needle above the rib to minimize manipulation or laceration of the vascular bundle located beneath the rib. As the needle advances, identify the pleural space by the presence of pleural fluid aspirate in the syringe. Placing a sterile gloved finger on the needle at the point where it exits the skin approximates the length of the insertion for the thoracentesis needle or catheter. During needle insertion, the open stopcock valve allows aspiration of pleural fluid while minimizing the introduction of atmospheric air. The pleural fluid is used for laboratory testing to help delineate a differential diagnosis.
So let's move on to chest tubes. So the purpose of a chest tube or pleural drainage is to remove air and fluid from the pleural space and to restore that pleural pressure so that the lung can re-expand. And it's done for pneumothorax and pleural effusion, as we've discussed before. This is a diagram of chest tubes in place. So for a pleural effusion, you can see the chest tube coming out here. You can see the fluid here in the pleural space. And for a pneumothorax, it's actually dependent on which area of the lung is collapsed due to air. And then so in this spot, in this time, we have a chest tube inserted here because the upper part of the lung must have been collapsed. And then this is actually as well, you've got another chest tube in here, which it's never, you typically don't have two chest tubes in place for a pneumothorax and a pleural effusion. And so they're just showing the different areas. So typically as air can rise, right? So typically the pneumothorax tube is a little bit higher, whereas the pleural drainage would be a little bit lower because fluid will drop to the bottom of the lung. So it's just showing the different insertion sites. So this is also showing a pneumothorax here, and as the chest tube is put in place, the chest will re-expand. Okay, so let's watch another animation on chest tube insertion.
The thoracic cavity under normal conditions is a closed airspace. Air or fluid entering the space competes with the lung, resulting in the collapse of the lung. Chest tubes are used to drain air or fluid to prevent severe complications. When making the incision, the space should be large enough to admit a finger. Keep the clamp close to the superior aspect of the ribs to avoid neurovascular bundle injury. Steady, even, controlled pressure provides control of the clamp once the pleura is perforated. Feel for lung tissue, diaphragm, or adhesions. Break up clot if found. Do not allow any side holes of the tube to remain outside the pleural space. A chest radiograph confirms re-expansion of the lung.
Now you can imagine how painful that is. And so the area will be frozen, but it's still very painful having a chest tube inserted. And your role is to be at the bedside to provide support to the patient. You will assist the physician or the nurse practitioner in setting up the chest tube insertion tray, and you will be involved in connecting the tube actually to the thorax or the pleural drainage system. But you will, and you may be asked to give pain medication prior to the chest tube insertion, but it is painful for clients to have this placed. So there are different types of chest tubes. You can have a Heimlich valve, which is a very small type of chest tube here. It's not it can be connected to your bigger, larger pleural system. So it can be connected to a drainage bag, which allows the client to move around freely without having to carry long tubing in a long collection system. So it really depends on the size of the fluid or the air. They can also go home with a Heimlich valve and drainage bag, but they can't go home with a huge drainage system. And then if they go home, the chest tube and the valve will stay in place until the excess fluid or air in the chest is gone and the lungs are inflated. So they will regularly come back and see a physician in the emergency department or see a respirologist or a thoracic surgeon. You can also cover the end here of this Heimlich valve with a gauze cover. And so that allows air to escape, which is fine. It's a one-way valve, so air is not going to go back into the cavity, but it's important not to tape the end of the valve. The end must remain open to allow air out at all times. And then you have your other tubes, and they can be a small chest tube, which is called a pigtail chest tube, or a larger chest tube. And again, it really depends on the purpose of placing the tube. Post-op surgery after cardiac or thoracic surgery, you typically have the larger tubes because you're going to be draining large amounts of blood. For a pneumothorax, typically you can put in a smaller chest tube. So the pleural drainage systems or a water-sealed chest drainage are typically scary things for nurses. And my advice to you is, if you are a new nurse working on a unit, to make sure you ensure you get good education from your nurse educator. So the water-sealed chest drainage systems, or your pleural drainage systems, they remove air and fluid and they restore the normal pressure within the lung cavity. It's a one-way system that uses atmospheric pressure to keep air from entering the pleural cavity, but also allows air and fluid to drain. So these are used when you have a persistent pneumothorax, a large pneumothorax, or a large amount of drainage post-surgery, or if there's an open pneumothorax or open pleural drainage. So compartments, you have the collection chamber, which is here, and this is the collection chamber, and this is something that you're going to review hourly. You have your water seal chamber here, which you will initially fill up to the 2 centimeter mark, or as per the type of thorax or drainage system you're using. And you will see something called titling in this water seal chamber. And titling is the rise and fall of fluid in this chamber, which is the direct reflection of the degree of lung expansion. And so titling decreases as the lung expands. And so in order to observe titling, when the suction is used, suction may be temporarily discontinued. So you would have to remove your suction to see the titling. You wouldn't do that. That's something that the physician or the nurse practitioner would do to see where exactly the patient is with respect to lung expansion. The suction control chamber, some thoraxes or drainage systems are connected to drainage, or to suction, sorry, and you need an order for that. And then the air leak chamber here the air leak is assessed here by fast and continuous bubbling in this chamber. And so this is good or bad. It can give you an idea of whether there is a pneumothorax there. It can also give you an idea of maybe there's something disconnected in your whole system. So those are the two different, they're not different, they're different manufacturers, but typically they have the same chambers. So in some important facts, you'll always keep the drainage system below the chest tube site, and it can drain with gravity or connected to suction. You always evaluate all connections to make sure they are taped and secured. So every time you come on shift, when you leave shift, it's your responsibility to evaluate the drainage for the amount, the color, and you mark it on the collection chamber as per the protocol. It's typically done at the end of every shift. You eliminate, you don't milk or strip the chest tubes. There used to be a protocol where you would run your hands along the chest tube to try and pull out any fluid. You don't do that anymore. That is not good practice, and it leads to increased pleural pressures, although you may see surgeons come along and still do that. And eliminate clamping of the chest tubes except to assess for the leak in the system per protocol. And again, you never clamp your chest tubes unless there's a protocol in place to do that. So this just gives you an acronym. So this is water drain. So W is water seals, and you add sterile fluid to the water seal chamber, usually to the 2 centimeter mark. Air leak is assessed by fast and continuous bubbling in this chamber. Titling is expected in water seal chamber. Elimination of titling in the water seal means the lung has re-expanded. Remember not to strip or milk the tubing. D is drainage characteristics, so the amount, the color, the volume. Record hourly and mark on the collection chamber. Again, this is per protocol. In an ICU setting, you may be reviewing it hourly, and anything above 100 mils per hour is cause for concern. And you want to also compare it to the previous hours. So assess output in comparison to the previous hour. And so if it's starting to decrease, that's a great sign. If it's going 100, 125, 150, then that's a concern. Identify if there's been an increase or decrease in the amount, and note when the chamber is half full, because you need to start thinking about when you're going to change the system. This is very important to review. Table 30-19, nursing management. It's very important. And when you look at this, you'll see that there's a section on monitoring wet versus dry. You don't need to look at this part, but it's very, very important that you understand the nursing management of pleural drainage system. I've highlighted some of them, but not to the extent that this table highlights. So very important for you to review this. So what are some of the chest tube complications? So chest tube malposition, it's been pulled, it's in the wrong spot, is the most common complication. And so that's why it's important for routine monitoring is done to evaluate if the chest drainage is successful. And you can do that by observing for titling in the water seal chamber to see if it's working, listening for breath sounds over the lung fields, and measuring the amount of fluid drainage to see if it's in the right position or not. Re-expansion pulmonary edema can occur after rapid expansion of a collapsed lung in patients with a pneumothorax or with evacuation of large amounts of pleural fluid. A vasovagal response can happen with symptomatic hypotension, and it can occur from too rapid removal of fluid. Infection at the skin site, so meticulous sterile technique. Now that sterile technique is dependent on your protocol within your institution, but meticulous technique during dressing changes can reduce the incidence of infected sites. Pneumonia from not taking deep breaths, from not using an incentive spirometer, and from splinting on the effective side. And patients with chest tubes need very good pain management because it is discomfort. They do have discomfort by having this large tube in place. So very good pain management. And shoulder disuse or a frozen shoulder from lack of range of motion. So all of these chest tube complications can be mitigated or prevented by good nursing care. So I think I've already showed you this, the chest tube insertion, so we don't need to review that again. And then chest tube removal, so removed when the lungs are re-expanded or when fluid drainage has ceased or decreased. And when the chest tube is removed, I don't know whether it's a delegated act or not, but nurses at Southlake can be trained to remove chest tubes. After the chest tube is removed, a chest x-ray is always done to ensure that the lung has not collapsed, that air has not entered the space on chest tube removal. And you always assess the patient for respiratory distress to ensure that the patient has not succumbed to a recurrent or a new pneumothorax. And then I've also included on eClass a chest drainage learning package. It gives a great overview again of the chest tube drainage systems and complications and what to do in the situations of an emergency. So I will see you in our Zoom class to discuss this in more detail.